Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is titled Enhancing Tuberculosis Prevention and Care. The speakers are Dr. Anurag Bhargava and Dr. Madhavi Bhargava, and I would like to thank both of them for readily accepting to do this session despite having extremely busy schedules. Likewise, I'd like to thank Dr. Sonali Sarkar, who's a professor in the Department of Preventive and Social Medicine at JIPMER Pondicherry. Dr. Sonali did her MBBS and MD medicine at Veer Surendra Sai Medical College and Hospital. She has mentored and guided several undergraduate students and postgraduates of Doctorate of Medicine and Masters of Public Health, and is currently guiding PhD scholars as well. Sonali has more than 120 publications in national and international peer-reviewed journals. And the reason she's here today is that one of her areas of special interest is tuberculosis, especially tuberculosis as it impacts maternal and child health and palliative care. Thank you so much, Dr. Sonali, for agreeing to be a moderator for this session. And thank you, Dr. Bhargava, for suggesting her. Last but not the least, we have Dr. Krishna Kumar, who's the clinical professor and head pediatric cardiology at the Amrita Institute of Medical Sciences, Kochi. He's also part of our think tank and supporters of Marvelous Medicine ever since we started 3 years ago. Dr. Krishna Kumar did his MBBS from Maulana Azad and his MD Medicine and Cardiology DM from All India Institute of Medical Sciences, Delhi. He later on went to do his pediatric cardiology training at Children's Hospital, Boston. He's established a pediatric heart program in the Amrita Institute, and the program is actually recognized as one of the best in the country. And he's actually one of the reasons we reached out to him through Marvelous Medicine was to talk about the large community-based studies that he's conducting for both rheumatic and congenital heart disease. But he decided to talk on his passion, which was about quality and improving quality. And people may be surprised as to why we are having a cardiologist to moderate a session, but that's because he has closely followed the Bhargavs in their work as well as their research, and he's one of the fanboys of the Bhargavs. So over to you, KK.
Thank you, Vidya. This is an extraordinary forum, isn't it? Marvelous Medicine. We just all are taken out of our little silos that we live in and forced to think outside the box and look at others. And that's what is beautiful about what you've done over the years. And remarkably, you've done it with tremendous consistency and persistence. So hats off to you. I have to start by acknowledging that, and I'm in awe of what you have achieved. Now, about Anurag, I have to tell you, so my association with Anurag was in All India Institute, and Dr. Nandi, I remember those years. I just still have vivid memories of the rounds that you used to conduct in GI surgery, where we used to flock to just, because again, you encourage this very wide, out-of-the-box thinking. It set no limits really to how specialists should go about taking care of patients, and cross-specialized, and talked about things completely that were of much wider purview. So this really attracted us. Now, in terms of Anurag, well, we share a common situation. We were in some ways outsiders to AIIMS. We did our MBBS elsewhere, and there was this subtle, at that time, prevailing, I wouldn't use the word discrimination, but there was this pervading feeling that, listen, these guys are different, we are different, and maybe somewhat superior. So we had a common bond, the outsiders. And I kind of took upon myself to make sure that the ones who come in after me are made to feel comfortable. But Anurag really struck me as somebody very special. And the reason is he thought well beyond the patient's medical illness. He delved very deep into the patient's background, into the social background, into where they came from and what their challenges in living were. And that to me was very important, because when I was raised in Maulana Azad, I was taught to consciously keep that element out of my life, out of taking care of the patient, because it was thought to be, it would come in the way of being rational, making good decisions for the patient. And here is, and I completely realized how wrong that was, especially in a country like ours. And Anurag really took that to an extreme level. And the group of them that went on then to Chhattisgarh and established something that was in so many ways extraordinary, a very inspiring work. We don't, the very fact that they undertook what they undertook in itself has been an example that really is very hard to emulate. But it showed us so many facets. It opened up our eyes to so many things that we didn't know and the world needed to see. So that was something that struck me. And of course, I've been following his career, and his passion was tuberculosis. I'm not going to talk much about it because he will talk about it. They will talk about what they've done together. But you know what? It's been such an inspiration. It's, to me, when I saw that paper come out in Lancet, I just can't tell you how happy I was, because it left behind, it said, it just vindicated so much on what he believed in. So, Anurag is a remarkable inspiration. For those of you, I think he's not yet written a book about himself, about his life, but somewhere close, I would recommend that you guys who are in marvelous medicine, who think out of the box, look at Paul Farmer's book, Mountains Beyond Mountains. We have our own Paul Farmer here today, who's going to talk about his experience in the country. And of course, I have to say, Madhavi, who's walked the distance all the way along and supported him. Again, I have to say, when somebody accomplishes so much, you have to give a lot of credit to the spouse as well. So, Madhavi, I don't have too much to talk about you because I don't know you as well, but I know it's your support that made all the difference to what eventually Anurag and you have accomplished. So with that, I think I should hand it over to the forum back again, Vidya. You can take it forwards.
Thank you, KK. We have Ravi Shankar on the line. Woody, what made you immediately suggest that we somehow get Anurag and Madhavi on Marvelous Medicine? The minute you read that, how did you land up on that article, and what made you?
Thanks, Vidya. KK sent the article to me. So the second I read it, it was, first of all, to me, sitting here in the United States, tuberculosis, like I wrote in my introduction, is almost like the plague, something that, you think was there once upon a time, something that we need to think about in the history of medicine. But then reading this paper, first of all, said that wasn't true. And secondly, I was struck by how, there's this belief that you cannot do really good research from India. Now, KK and now the Bhargavas have showed us that is really not the case. Just the quality of the paper was so fantastic that I immediately sent it to you and asked you if this would be a good topic for us. So that's it. Thank you.
Thank you. Over to you, Dr. Anurag.
Yeah, I must say I'm feeling a little overwhelmed by the occasion because when KK was speaking, I hold him in the highest regard. And as he said, I was one of the people he took under his care, so to say, at a time when. But more than that, again, we don't want to go, but he has done a remarkable work in his own journey. So today, thanks to you and Dr. Samiran Nandi, again, like KK was saying, it was fascinating to see how he took rounds at the bedside with a very holistic view. And I think always it will just remain in my mind how things were done by him. So I'll just share my slides. We have lots of slides, but yeah. So we are based in Mangalore. We both teach in a medical college in departments of medicine and community medicine. But what is common for both of us is that actually we are both clinicians who did their formal training in public health in their 40s. So actually, yeah. So, but we are both clinicians and public health people. And as if I paraphrase a quote, which is applied to religion and science, without public health, clinical medicine is blind, and without medicine, clinical medicine, public health is lame. So we are both on this page together. So this presentation is dedicated to the large number of people in India and millions who suffer from TB every year, and I think quite unnecessarily, and the lakhs who die, and their death is almost seen as inevitable and as a part of the process. But again, it is very, very avoidable. So if I just draw your attention to the litany of Sir Robert Hutchison, and the first line says, "From too much zeal for what is new and contempt for what is old." And it ends as, good Lord, deliver us. So I'm not going to say anything which is not very obvious to common sense, but which has been somehow not part of the discourse on TB and with grave consequences. And Sir Charles Handy said that good ideas are usually not new ideas, but old ideas resurrected at the right time. So at a time when, in spite of our approach to TB, which deals with treatment and vaccines, we are still not able to achieve that decline that we are hoping for. It is good to look at what we are talking about today. So if you see the TB problem in India, it is still humongous. Nearly 3 million new patients a year, more than 330,000 dying annually of TB, a highest magnitude of drug-resistant TB in the world, the catastrophic effects on families, apart from expenses, children dropping out of school, people not able to return to work. There are unmeasured effects on post-treatment morbidity and mortality. And we have set ourselves an ambitious goal of reducing TB incidence by 80% and reducing mortality by 90% by 2025. So that's very ambitious. But yes, some things can contribute to that. So whenever now we look at TB, it's always that India is the global leader in TB. And when we go out of India, we are screened for TB. But was India always the highest TB burden country in the world? And you'll be surprised to know that authorities have said that actually India in the 19th century had very little TB. And this is an official publication of the British Empire saying that in India, TB is directly proportional to contact with Europeans. So, so that is what TB was in the 19th century, where 1 in 4 of every Londoners was dying of TB. And in India, British physicians were seeing very little of TB. So something happened from the 19th century onwards in India, which led to the problem as we see today. And after independence also, our neglect of certain things has again contributed to this continuing high burden. Let me put my propositions up front. So I'm putting forth 4 noble truths realized about tuberculosis over the last 20 years. And the first is, mycobacterium tuberculosis is a necessary but not a sufficient cause of tuberculosis. Anti-TB treatment is necessary but not sufficient to reduce TB deaths at an individual level. Treatment of infectious cases is necessary but not sufficient to control TB at a population level. The adage was that the prevention of TB lies in the cure of TB. That's not true. And finally, what Madhavi is going to present it is possible to control TB, that is reduce TB incidence without recourse to drugs or vaccines. So just a personal note here, I met Madhavi when I was working as a faculty in a rural medical college in Gujarat. So I moved from AIIMS to Gujarat, and to practice medicine at a more human level, I found that I was losing perspective in the kind of high pressure situation in which we deal with patients in AIIMS. I also wanted to explore practicing medicine at other levels of care, and I realized then later when I did practice medicine at primary care level, how enriching it is in all terms. I also wanted to deepen my understanding of problems of health and disease, and at least if I thought that if one works at other levels, we can make a difference over a long-term period. So our journey, the Danish philosopher has said that life can only be understood backwards, but it must be lived forwards. So this is kind of map of my movements. Madhavi was born and brought up in Gujarat. So, but together we have worked in the most transformative experience was, of course, in Chhattisgarh in the village Ganyari, and then our short stay in Canada. But then we returned to Uttarakhand, and now we are working in Mangalore. But over this period of time, some things have sort of, we basically started with service and then advocacy. And then finally, we found that, advocacy doesn't work without generating some evidence. So that brought us to research. And over the 20 years that we have worked, we have built a perspective which goes beyond the biomedical model of health and disease in which we routinely operate. So I received an invitation from from a rural medical college in Gujarat and joined as a faculty there. And I was quite fascinated to see what was happening in the milk capital of India. This was District Anand. And I can challenge that there is no comparison to the animal care model of Anand, of Amul. Any farmer with a sick animal can get care at the doorstep within 2 hours. And delivered at a flat rate of, at that time, it was 30 rupees. And the people who pioneered this was, again, the technical mind was of Dr. Varghese Kurian, whom I had the privilege of meeting once before moving to Chhattisgarh, and the community leader, Tribhuvan Das Patel. So actually, I worked in a foundation which was supported by Amul purely in a voluntary capacity, apart from working in the medical college. And what Dr. Varghese Kurian told me was, it's nice that you're going to a tribal area and our people have an immense reservoir of traditional wisdom. So if you can marry your science and technology with their wisdom, then you'll do something good. And the other thing he said, that if you want to establish credibility, it is only through service. So in 1999, we were given this land of abandoned buildings, which were just lying abandoned for 20 years in a village near the town of Balaspur. So Jan Swasthya Sahayog, as KK referred, was a non-profit organization founded by a group of like-minded individuals, Yogesh, Jain, Raman Kataria, their wives Anju and Rachna, Bishrup Chatterjee and Madhuri Chatterjee, Dr. Satyamala, Dr. Pramod Upadhyay. So it was really a very nice nucleus of committed people who started work. And the vision was to develop a community health program with a referral facility. So we started work in the end of 1999. And I don't have a recent photograph here, but it is completely transformed now with trees and buildings. And yeah, now it's, so there's just some patients waiting outside the JSS gate. All of us who work in rural areas as well as in urban areas have encountered this poverty disease trap, which actually perpetuates, the disease perpetuates poverty. And all we can hope for is that the disease does not lead to poverty by providing access to care and by minimizing cost of care. So within this poverty disease cycle, what we encountered was tuberculosis. Poverty leading to tuberculosis and tuberculosis leading to more poverty, sometimes because of deaths itself. And it was the most common killer disease that we encountered there in rural Chhattisgarh. Before we settled there, we were told that TB is not very common here because people are not living in crowded conditions and they have enough to eat. But that was the most and this was told by a person who ran a pathology lab in Bilaspur. But nothing could be farther from the truth. And the first year we had diagnosed 500 patients. So over a period of time, JSS really has flowered into service provision, both at the village level and with the referral hospital, which has now 4 OTs. There's a training center, there's a nursing school. We were developing appropriate technology for prevention of care. There's also a demonstration plot for agriculture and work in animal health, and then research and advocacy. So time is limited, so I will not dwell on these activities, but just some snapshots here of the village health workers who over a period of 2 decades are managing sub-centers themselves. These are all women selected by the villages for training by JSS and delivering care there. This is the, just one of the outreach clinics in the middle of a reserve forest. And even in that outreach clinic, you can see we are providing lab services for microscopy and pharmacy, again, to a population which does not have access. What I just wanted to show this this thing from the paper in 2015 by the group. And there's a serious underestimation of the magnitude, severity, and complexity of health problems in rural areas. You can see 600 patients of severe hypertension diagnosed in any 1 year, followed by tuberculosis and then cancers. So you have the whole gamut of communicable, non-communicable diseases actually which require even more care here in this setting, coming to a health center which is providing them access. Again, one of the women with a 20 kg ovarian cyst, waiting for surgery for 4 years. And this is my friend and colleague, Dr. Raman, with Madhavi in her previous avatar as a surgeon. So Madhavi and Raman are operating in the theater. But you can see this 3 children with chest tubes in a single time, and you can see their state of nutrition. So as somebody referred to that, maybe tuberculosis was something in the past. Yes, it was a disease of the past in the West, but it's a disease of the 19th century that we are still sort of, it's still with us in the 21st. So these images are, not of kind of famine conditions, but, patients with TB. And the last person, the person with absolutely skeletal, he belongs to a particularly vulnerable tribal group called the Baigas. And not only in this terms of the cachexia, but when I had a session with the village health workers and asked them whether, TB is curable, there was just silence, because none of them in that area at that time, when the national program actually had not even spread, the DOTS program had not spread, they did not recall a single person who had been completely cured of tuberculosis. So this was like the pre-chemotherapy era there. And they actually started crying because the young widow in front of me, actually her husband had died of TB. She was hardly 19 years old. And when we inquired about a family history of one of the patients, she said she had 8 uncles and all died of tuberculosis. So this is a family of people with tuberculosis. One of them had drug-resistant TB. And when we asked him other people among the family, he brought his father and his sister. Both were suffering from tuberculosis. So really speaking, it was a problem of families and communities rather than individuals. So this person defaulted. This is a defaulter from the national program. He was given doses which are not suitable for his body weight, and he developed side effects and stopped therapy. And then he had to be treated, hospitalized at our center for almost 6 weeks. And this is, again, I'm talking of the biomedical model. According to the biomedical model of disease, this patient is cured because his sputum is negative at the end of treatment. But what has he been left with is a completely destroyed lung. And we are not even registering the fact that he will not be able to work for the rest of his life, although classified as cured of TB. But JSS actually, I think anybody who works in primary care actually goes through a process of unlearning and relearning. And we found that actually we had to do things which were not part of the national program at that time. The national program, for example, had a diagnostic strategy requiring 2 positive smears. And in our case, the patients came from distance. They could not stay overnight. We felt that 1 smear was enough because we'd seen the patient. In the national program, it was only HIV screening, but we were doing a clinical screen, nutritional assessment, HIV, diabetes, and hemoglobin. After seeing some of the problems with intermittent therapy, including higher relapses coming from the program, we actually used only daily therapy. And we were using weight-based dosing so that nobody received excessive dose. Because of the issue of resistance in India to INH being high, we were using in the continuation phase an additional drug. Now, actually, the national program also uses HRE, but at that time, it was considered unorthodox. And drug-resistant therapy was not available to 2008, but patients were coming to us. So we were forced to deal with, patients with drug-resistant TB. This is just a information leaflet that we had provided to patients and their families about TB and its treatment. And this paper actually in the National Medical Journal of India, thanks to Dr. Saminanda, he might remember this paper, but we raised the issue that, intermittent therapy has probably, poorer long-term outcomes. The dosing of drugs has to be weight-based, and we need really a rapid upscaling of the MDR-TB initiative. Subsequently, actually, a number of studies showed that our concerns were justified because the relapse rate on intermittent therapy was found to be more than 10%. We even represented to the committee which was looking at drug regimens, and in 2013 they changed. So now I'll specifically, after this general thing, I'll just talk of TB here. So G.K. Chesterton quotes sort of challenges us to see not the solution, but the problem in its entirety. And you have to step out of the frame, as KK said, think out of the box. So 3 questions which were posed to us and which still is posed to everybody in India is, why do so many Indians die due to TB every year? Why do so many Indians, chiefly the poor, develop TB every year? And what needs to be done to prevent TB and TB deaths, again, chiefly in the poor? Because I have not heard of any, parliamentarian dying of TB. All the death, all the disease, burden of disease is mostly in the poor in India. So when we are talking of the framework in which we are operating, the germ theory, which established that the infection with the tuberculous bacillus is a necessary cause of disease, was a great leap forward because it led to diagnostics, it led to development of antibiotics, and it led to development of vaccines. But very soon after, within 20 years of what Robert Koch discovered was, in Vienna, von Pirquet found that 70% of children by the age of 14 were positive for the skin test for TB. That means they had been infected, but only a small minority had disease with it. So it was clear that in this case, infection was not a sufficient cause of TB disease, because infection was widespread, but disease was only occasional. This I would just spend some time. So the germ theory of disease, which is largely focusing on infection, was later replaced in all other diseases by the epidemiological model that disease occurs with it as an interaction between the agent, the host, and the environment. And if you have exposure to TB in India, which is because of 3 million people infecting maybe 10 others in a year, so about 30 million are getting exposed. A proportion of them get infected. Now, in TB, as I said, disease is unusual. So most of the patients under the effect of a normal immune system are able to maintain TB in a dormant state. And only in 10% it progresses over lifetime. And again, host factors which impair immunity can increase the risk of this progression. Host factors which strengthen immunity, or vaccines or TB preventive treatment can reduce the risk of progression of latent infection. So this is the crucial part. If you have about more than 300 million people at risk of TB, then this is the critical place where we can exert effect on TB control. On the other hand, when the person develops the disease, again, it's not the germ which is the deciding factor, but the access to healthcare and the status of the person itself in terms of immunity, which determines whether this disease will result in death, cure, or just persistent, resistance. Again, if you see the poor in India, they have environmental conditions like overcrowding and poor access to healthcare, which make it more likely to get infected and to get diseased. Of course, we are going to talk of undernutrition here, which is a major factor. So rather than think of TB only as an infectious disease, which will address with drugs and vaccines and treatment of TB infection, which, by the way, in 300 million at risk is going to be a huge logistic enterprise, we have to think of framing the disease in other terms as an immunological disease, which you can address risk factors which impair immunity to TB. And 5 of these major ones are nutrition, HIV, alcohol, smoking, and diabetes. So, and finally, you also have to look at TB and its outcomes as a problem of equity and quality of healthcare. So there are gaps in access, content, and quality of care which need to be addressed. if you are going to reduce the number of TB deaths in India. So when you talk of immunity being the crucial element in the balance between the infection and the disease, it has been long known that the leading cause of immune deficiency in the world is not HIV but malnutrition. And a nutritionist had coined the term that the immune dysfunction which results from this is nutritionally acquired immunodeficiency, to just highlight it in contrast to HIV. And numerous studies consistently have shown that the relationship between nutritional status by BMI, body mass index, and TB incidence is inverse and exponential. So as the body mass index increases, the TB incidence can decline exponentially. And in this paper, actually, they showed that for every 1 unit increase in BMI, your TB incidence can decline by 14%. Now, just to tell you, at the moment, our TB rates are declining by 2 to 3% per year. So here we are talking of the nutritional status being a major determinant of TB incidence in a country. The first question was, why are so many people dying of TB in India? And we were able to look at the impact of undernutrition on our patients, which is visible, very obvious to you in our patients. And this was about 1,700 patients between 2004 and 9, followed up till the end of treatment for weight gains, etc. And we assessed what was the impact on mortality. This is the first paper which actually looked at nutrition status in India in terms of body mass index in adults. And what we saw was that the median BMI of women was 15. So 50% of women had a BMI less than 15. It went down to below 10. And the weights were again median of 34 kgs. And in the men, the median BMI was 16. Again, half were severely underweight. And adult Indian rural men in rural area were having a weight of 42 kgs. Now, we know that the NINS said that the reference weight should be something like 70 kgs in Indian men. The NTP data on BMI is still not available on a large scale, but the weight data shows that actually the weights that we saw were not very extreme and actually comparable to the weights in the National TB program. So clearly, this is not a problem localized to Chhattisgarh, but in parts of India. And these rates of BMI at baseline were increasing the risk of mortality by 2 to 4-fold. So while you're talking of TB treatment, it is also important to address this very much correctable risk factor for mortality in our country, where undernutrition is so widespread and severe in our patients. You can see this histogram of BMIs and hemoglobins, and again, it captures how low the BMIs can be, and with the maximum at around 15 and 16. Again, hemoglobins as low as 5. And this story is going to repeat itself in Madhavi's presentation. And what we found is that if only the undernutrition was related to disease, they should have recovered to normal weights at the end of treatment. But because of the lack of access to adequate food, their nutritional status, even at the end of treatment, most of them remained underweight. So they were cured in a sense, but still underweight. And across the world, undernutrition is a consistent risk factor for mortality, increasing the risk about 3-fold. And again, an old observation was that actually a principal determinant of TB mortality is nutrition. Undernutrition actually has a very series of important adverse effects on during treatment. Higher risk of extensive disease and death, higher risk of drug toxicity and malabsorption. It delays sputum conversion in both drug susceptible and drug resistant TB. And even after treatment, if there is poor nutritional recovery and functional recovery, higher risk of relapse, 4-fold higher risk of relapse, and again a risk factor for post-TB treatment mortality. Now the program was in India because there was no attention to the nutrition status of patients. The program was actually agnostic to weights. And the national program guideline 10 years after the first statement was made that, we are giving them higher dosages. They said that irrespective of body weight, adults will be given the same dose. So this was completely inappropriate. And it is fortunate that actually the program revised this guideline. And now there are weight bands for people even below 30 kgs. This paper and then subsequent work led to a very welcome development of a guidance document for nutritional care and support for patients with TB in India. And we were invited to lead this effort. And we organized a workshop, and this document, came about, and it was released in 2017. In 2018, the government sort of decided to give a direct benefit transfer of 500 rupees a month, which is not adequate, but at least it's something, to all TB patients in India to enable a better diet. So this was one concrete result of the work. We also developed an Android app to enable, a nutritional assessment of TB patients and how to give them proper advice. So this was in technical collaboration again with McGill, and the government accepted this application. We also gave action points. Finally, again, we looked at TB deaths closely, and we felt that these are predictable and preventable. And if we have more comprehensive assessment and more comprehensive clinical care, which goes beyond just the infection, but looks at severity of disease, which looks at the comorbid conditions which are risk factors for mortality, like diabetes and HIV, then this comprehensive care model can really prevent deaths. And we found that again, our results showed that nutrition status is again a good surrogate marker for disease severity. So measuring that at baseline again could be a good predictor. Deaths are also caused by delays within the system, again, partly because of the problems of patients, probably because of the referral. And when we look at quality of care again, there is still no risk assessment. Now it has been done for last 1 or 2 years in a differentiated care model. But basically the kind of assessment that any patient should receive for a disease which can kill, like a measurement of vital signs, like measurement of hemoglobin, somehow TB patients was seen as an exception to this. So the inpatient component of care was de-emphasized, and I think this needs to come back now. The second question was, why are so many people with, mainly the poor, are developing TB? Again, for the first time, we calculated in a paper what proportion of TB incidence in India could be related to adult undernutrition. And as you know, BMIs, the prevalence of undernutrition overall is declining, but it still is high in the communities that are most vulnerable to TB. So if you take 25% as low BMI, it is still a high prevalence situation. It's a serious situation. So I will not go into details here, but we found that undernutrition in adults was quite common. 1 in every 3rd adult at that time, the data showed, was underweight, and the problem was more so in rural areas, in poor and the SC/ST community. So this final thing of more than half of TB in India was related to undernutrition and could be prevented by addressing undernutrition as a risk factor, came out from the analysis, and clearly which showed in South Asia it was actually undernutrition which was driving the TB epidemic, as against Sub-Saharan Africa, which was because of HIV. Again, fortunately, now every year the WHO is putting out what proportion of TB is related to different factors, and here again undernourishment is the key factor globally, and in India again it actually leads to more TB than all other risk factors combined. Lastly, I got an opportunity. This was part of my master's thesis, and it completely accidental that I chanced upon this experiment, which was in the pre-chemotherapy era. It was called the Papworth experiment. And the Papworth was basically a colony of TB patients and their families founded around a sanatorium, and where they were provided employment, stable employment, better housing, and an emphasis on good nutrition. So McGarrison, who is the actually father of nutrition research in India, had a paper where he said that actually there's only one example should suffice, that at Papworth, no child who was born there contracted TB of any kind. So that was remarkable at a time where there were no drugs or vaccines. This kind of social intervention with housing, employment, and adequate nutrition. And McGarrison thought that it was mainly because of adequate nutrition which maintained the child's resistance. Despite a very high rate of infection, everybody got universally infected by age 5. There was very low incidence in other contacts, 0 incidence under 5, which is the most susceptible, and almost 84% decline in TB incidence. So this was again without drugs or vaccines at that time. And the persistence of my guide, Dr. Dick Menzies, he was asking me so many questions about Papworth. Finally, I traced one child who was admitted to Papworth in 1929, in 2011, and I had a correspondence with him. So this is the same person, Peter Patel, and he said that, yes, we were poor but never hungry. I think this is a very important statement, that poverty should not go along with, misery of hunger. And these two are separate. You can be poor in some way, but you should not be hungry. So when we contrasted our results from the Papworth reanalysis with other biomedical interventions at that time, actually the Papworth was the one with significant impact on TB incidence, where actually mass INH preventive treatment and a new form of BCG vaccine was not actually shown to be effective at that time. And a very interesting anecdotal thing from the prisoner of war concentration, prisoner of war camps in Germany. The Britishers, this was an accidental trial, again, had only 1.2% of TB developed in 1.2% against 15% in the Russians. And the intervention was their access to a Red Cross rations of 1,000 calories and 30-gram proteins a day. They were living in the same conditions of overcrowding and stress, but this intervention was crucial in protecting them from TB. As we see, TB declined in the West and became history even before the first drugs were discovered, or even before therapy was discovered. And after the therapy was discovered, the improved conditions of living and the therapy really accelerated its decline. So when we talk of, when I said that TB treatment is not alone to prevent TB, it is because when we are talking of a person with disease and giving him treatment, it is decreasing the period of transmission, but it is not doing anything on the pool of patients, the large number of people with latent infection who might progress to TB under the effect of risk factors like undernutrition, diabetes, etc. So this is my last slide. It's it was just to be provocative. A candidate vaccine against acid-fast bacilli in India is the adequate balanced food vaccine, which has all these wonderful characteristics which could otherwise get you a Nobel Prize. Orally active, it can promote growth, it's polyvalent. If given to pregnant women, may decrease infant mortality, mass production possible, no IPR issues. But what I got was, 2 minutes of fame in Satyamev Jayate for this vaccine. So anyway, Madhavi will now take on the rest of the discussion on how, based on the work that we had done, we tried to implement a nutritional intervention in a state like Jharkhand, where there is a problem of TB and undernutrition. And she will just take us through that. But again, as I said, this is the collective work. I've just, shared this thing, but yeah.
I'll unmute myself, and I'll also switch off my video so that I don't distract myself. And also keep it short. I understand that there should be adequate time for discussion. So,
Dr. Madhavi, please feel free to complete your talk. We are doing fine, and
okay.
and you can keep your video on. And if I can just briefly interrupt, Dr. Nandi, if you would like to say something before Madhavi starts, we'd like to hear from you, sir, Professor Nandi.
I think it was one of the most brilliant talks I've heard. And I'm very pleased that I'm part of the teaching of Anurag Bhargava. And I think that I was I judged, I gave him the best paper award in the BMJ, is that correct? In some BMJ.
Yeah, you were the jury for the BMJ Research Paper of the Year in 2014.
2014.
14, yeah. It really, I think, of course, it was a very left-wing type communist paper saying that you neat, work off business that you have to, social intervention is more important than health intervention. I mean, important for health than medical intervention. And he's really convinced me that the main problem would be not to deal with doctors, but politicians should wipe out TB. It was wonderful. And thank you for allowing me to listen.
Thank you, sir. Over to you, Dr. Madhavi.
Thank you so much. So I'll be talking about the recent trial papers that we just published with the beautiful acronym RATIONS. It was like a eureka moment, I think, when Anurag came across this reducing activation of tuberculosis by improvement of nutritional status, very apt for this. And the two main things that came out from Anurag's presentation and what were addressed in this trial were that if we give nutrition supplementation, can we reduce new TB incidence in household contacts of patients with infectious TB? And by giving nutrition support to patients with tuberculosis, can we improve their outcomes? So this was an endeavor of a very large team done in collaboration with Dr. Banu and Dr. Watson from NIRT, and a lot of support from Central TB Division, State TB Cell of Jharkhand. And it takes a village to do a trial. So this was how we started. We had a training of almost 5 days with many experts coming and teaching various aspects of trial, which included nutrition assessment, counseling, talking to the people in the community, GCP training, certification. And we also had 3 TB survivors, which brought in sensitivity within the whole group also. And when we started, there were a lot of questions about safety of these workers from tuberculosis, without them knowing that they are going to have another disease they are going to face, and that was COVID during the trial. So the trial area was in eastern part of India, Jharkhand. We selected 4 districts. It was a cluster randomized trial, so there were 28 tuberculosis units. So these are basically units that correspond to blocks, and for administrative purpose, the program has divided these blocks into units, and each unit will have a primary health center or a community health center where TB patients are taken care of. The area that we covered was almost 2,100 square kilometers, and it was a 3-year trial. We started after a preparatory phase, we started in August 2019 and completed in 2022. So as you can see, the intervention and control arms are of not families, but clusters of tuberculosis units, because it was a food trial, and to have individual households randomized would have been very unethical and uncomfortable. It's a very beautiful state, rich in natural resources, but a lot of problems of livelihood, access to care, access to, even simple access on the road. And the last picture is something taken by Anurag. It is a bicycle that goes into jungles to fetch firewood, and they can carry up to 50 to 80 kgs of firewood back home. So coming to the trial per se, we had 2 sets of population within the trial. One, the patients with infectious tuberculosis, 2,800 patients, 1,400 in each arm. This was all within the National TB program. And their household contacts, 10,345. So these household contacts from the 14 clusters were randomized into control and intervention group. Accidentally, we had more household contacts in the intervention arm, almost 900 more. And this is the arm where we, as people, I mean, as advocates of nutrition support, wanted less incident tuberculosis, and we had more household contacts there. The primary objective, as I said earlier, was difference in incident TB in household contacts in both the arms over a period of 2 years of follow-up. And the secondary objectives were in the patients per se, of improving outcomes, that is the death, their weight gain, their ability to work, that is the functional status, their whether compliance is a major issue, so loss to follow-up, and side effects to TB drugs. So for ethical reasons, patients did not have any control arm. So patients received rice, sattu, which is it is a powdered chana dal, roasted chana dal, and it is very commonly used in Bihar and Jharkhand. And they have a lot of sweet and savory recipes for that that they can use. So that was the only ready-to-use food that we used in this food basket. And they were given skimmed milk powder, which was non-sweetened, some oil. So we started with groundnut, but that had a problem of keeping quality, and there was infestation in the first batch. So we withdrew that and we switched to this. And this was decided in collaboration with the National Institute of Nutrition, and it provided almost 1,200 kilocalories and 52 grams of protein. Along with this, we gave one recommended dietary allowance of multivitamins. The family in the intervention arm, the adult contact, received 5 kg of rice and dal, as simple as that, along with multivitamins that provided 750 kilocalories of proteins and 23 grams of 750 kilocalories and 23 grams of protein. And half of this was given to all children less than 10 years of age. So it was an 1,100-ton trial. Apart from being called a rations trial, we distributed a lot of food, and never in my life had I taken care of so much of logistics. I learned a lot in the process. But more importantly, the cost of the basket, if we look at the 2019 prices, as you can see, is not very high. 1,100 per month for patient and 325 for an adult contact, and this is inclusive of the transport cost. The delivery cost. Transport cost is much more, and we are actually embarking on cost analysis also. So even if we consider inflation, this is something still doable, we would say. Food delivery was the biggest task in the initial part of the trial, navigating difficult situations, places where there were no roads. We created sub-depots where a lot of supportive supervision was required. We had to teach people first in, first out principles and how to maintain registers. And whenever there is a trial where food is delivered, the question is, how did you ensure that food that you gave was consumed? So we definitely did not do any directly observed therapy, DOTS for at least our food consumption. The weight gain was our surrogate marker of consumption. We anticipated some amount of food sharing, but we made sure that we gave enablers of good counseling, spending time with the families so that they understand the importance of food being given to the patient. But apart from that, we had some processes in place which helped us make sure that patients and the families consumed as it was useful for them. So there were network of 4 sub-depots. We maintained stock registers. We used WhatsApp for geolocations, where every time the food was delivered, the health worker would share the geolocation on the WhatsApp group, which was randomly checked by the project consultants intermittently. Every time the food was delivered, the head of the family or the adult person in the family would countersign it. And at the household level, every time the health worker went, they would again counsel, check at least for the empty milk packets. And we realized that the availability of participant information sheet to the household contacts was something which came very useful. We used to get calls from Jharkhand sometimes in Mangalore saying that this time the food delivery has got delayed if it was delayed by a few days. Of course, there was a lot of triangulation that was happening at the community level. So there were random supervisory visits that we would do, phone calls that were made to household contacts by staff at Ranchi and from us. But in the village, there is a lot of feedback that goes on in the community. So it's not a faceless transactions. So Sahiyas or Ashas, which are part of the government health system, village leaders, program staff, we come to know from various places. So pilferage happened at least twice, and those field staff had to be relieved from duty, but otherwise things were pretty smooth, I would say. So we had some baseline evaluation, simple measures, anthropometry, height and weight, that is. We screened all the household contacts for any concurrent tuberculosis case by their symptoms. And we checked few important points for the nutrition status and severity in the patients, that is whether they had pedal edema, which was suggestive of severe undernutrition, their blood pressure, their oxygen saturation, and something which is Eastern Cooperative Oncology Group score, modified one, that is ECOG score, which I will come in a bit. And these indicators helped us triage the patients with severe illnesses, and that we could, apart from that, we also checked for anemia so that we can facilitate their admission and prevent avoidable deaths. So we had monthly follow-ups for first 1 year and quarterly after that. Coming to the ECOG, the numbering is a bit counterintuitive, 0 to 4, where 0 is people like you and me who are working normally, and 4 are those who are bedbound or chair-bound and not able to take care of themselves. This is just an example of how supporting supervision was happening when we were not there in Jharkhand. So we made almost 20 to 22 visits together and sometimes separately to Jharkhand. This is one of the patients whom we received information from our health worker, and we would love if our postgraduates also report us like this. A patient with a weight of almost 31 kg, BMI of 13 kg per meter square, with hypotension, with poor saturation, severe anemia, and a poor ECOG score. And fortunately, we could save this patient by timely admission. Some more pictures. We had some sub-studies where we looked at body composition, hand grip strength. We did some, in a subsample, we also did micronutrients, because that is something that interests TB researchers, that if we can give a pill and people improve. So coming to the results, our population was mostly tribal, and almost more than 80% were underweight. Out of that, severely underweight was that is less than 16 kg per meter square. If we look at almost half of them, and a special category of severe underweight, extremely severe underweight, less than 14, almost 17%. Anemia was very frequent, severe anemia in 7.5. And if we look at one of the important patient-centered, problem that a patient suffers, and that is inability to work and move around, only 3% were able to work at the baseline. We'll keep this information in our pocket for some time to see what happened in the end. Looking at the baseline characteristics of our contacts, I'll not go into great details, but BCG was almost 70%. People were accessing PDS. Rice was available to them, which is mostly rice and wheat. The TB preventive treatment was limited in those times. It was not extended to other population. It was only 16%. But more importantly, the underweight overall was 34%. That is, and in children, it was almost 50%. Now, coming to the outcomes, in all, we had 218 new incident TB cases over a period of 2 years of follow-up. And the numbers may not seem large, 96 in intervention, 122 in control arm, But when we look at the incident rate ratios and we adjust for the usual factors, it was 39% reduction in all forms of TB and 48% reduction in case of infectious TB. So just to clarify, the co-prevalent TB is TB that was detected in first 2 months after the diagnosis of index patient with TB. Household contacts, they panned out when they had TB. We had, most of them were adults. The maximum challenges were in diagnosis of extrapulmonary and child contacts. But we were able to, in spite of a lot of challenges during COVID time, we were able to do microbiological confirmation in almost 153. If we look at the median weight gain, very modest, I would say 1.6. We would have loved to have more weight gain, but probably it was COVID time. And this was not on top of what they were already having, but probably the only food they were subsisting on at some point, at least. Outcomes in our patients, the first population, treatment success was 94%. So if you look at the National TB Elimination Program treatment success rates, it is 82%, as indicated in the last report. So almost 10 percentage points more. A microbiological confirmation in 49%. And weight gain in patient was good for 4.6 kg. And we'll see how it depended on their baseline weight. Unfavorable outcomes were in 5% with death in 3.9, and some loss to follow-up in mainly because of COVID times when people migrated to the places. For the program, some important learnings were predicting and preventing TB deaths. We saw that a very modest gain, weight gain in first 2 months helped reducing tuberculosis. Other important predictors were low body weight at baseline, poor performance, that is ECOG 3 and 4, and diabetes. So, and unfortunately, in spite of all our efforts, 77% of deaths occurred at home. Median time to death was 46 days, and 5%, just a modest weight gain of 5 kg, 5% of weight gain from baseline reduced the hazard of 60%. And Dr. Sonali is here in the cohort in which she was also she was also an investigator. It was already seen that if we do not give nutrition support, 60% either had same weight or even reducing weight. So the usual understanding that, we start treatment and the patient starts gaining weight automatically does not happen. So some comparison with recent evidence and cohorts. So here, important to note, when we have such underweight patients, those patients with less than 35 kg, our cohort had half the mortality as compared to others. And as I mentioned, ECOG, 3% were able to do normal work. In the end, after the intervention, this was 75%. So this is something very important from patient's perspective, and it does not get reflected in many of the TB reports from various countries. If we look at the mortality, as I said, it was 3.9%, but if we, devil is in the details. So if we look at the stratified case fatality, those with less than 30 kg, those between 30 and 39, the mortality was much higher. Those who were not mobile, the mortality was much higher. And another question that we come across is that people are already getting PDS. If we give more food, is it not that they will become obese? So the weight gain was very modest in those above 18.5 BMI. And as we can see, in those who are undernourished, the weight gains were close to 7 kg. So again, there are some heartwarming pictures. A boy, a 19-year-old, completely bedridden, started walking with a stick, was able to stand, and at the end of the intervention period, he was able to flaunt him able to ride a bicycle. The patient that I had shown earlier was able to stand at the end of 2 months. And this is a lady who was postnatal, had developed tuberculosis, and were beautiful, sprightly, brightly in the end. So key learnings, I will end my presentation in a bit. So key learnings in prevention. If we, 1 in every 3 contact is underweight, so we need to think of family support, and especially in communities where the undernutrition levels are high. The protection, although this is not a very comparable intervention, is as good as the vaccine that is still being developed. It can complement, so it is, the nutrition support should not be seen as a competing intervention, but it can be a co-intervention in other initiatives such as TB preventive treatment and vaccination. The reduction in undernutrition is modest, 28%. But if we look at number needed to supplement, we need to supplement 30 households to reduce incident 1 TB case in the family members. In case of TB care, a lot of patients, more than 80% are underweight. They have anemia. Nutrition support, as we have seen in, of course, it was a trial condition, but it was feasible. It was definitely acceptable. And we have some wonderful interviews in our qualitative sub-study. We could reduce deaths. A modest 5% weight gain can protect people from dying in first 2 months. And again, if we look at the number needed to supplement, 1 TB death can be averted by supplementing 48 patients, and those who are severely underweight, only 14 need to be supplemented. And we could do triage and referral, something known as differentiated care model, where we could save lives. So just a little bit of an update. To our surprise, it figured in the Lancet, milestones of important studies. It was a little embarrassing for us to be there. But yes, now it is part of up-to-date guidelines, and this is our team in the end. Finally, it was what they gave us was what we are presenting. So we are very, very grateful to our committed staff who also had COVID. Their family members had COVID, had a lot of problems throughout these 3 years, and continued to work in spite of that. And our learnings have been a journey, as Anurag told, so we cannot forget our co-workers from Jan Swasthya Sahayog, learnings that both of us acquired at McGill University. And of course, our family, our 2 boys who know more TB than many of the postgraduates in our respective departments, and the child support team. Thank you so much.
Thank you, Dr. Madhavi. Dr. Sonali, for your comments first, and then we'll go to Gege.
Sure. Thank you very much, first of all, Dr. Anurag and Dr. Madhavi Bhargava. It was actually a privilege listening to your talk, and I don't know whether I deserve this or not. It's an honor to moderate your session. So really, thanks a lot, Dr. Anurag, for recommending or suggesting my name. I've always, enjoyed listening and learned a lot. It's actually an humbling experience just listening to your talk. But first of all, congratulations on completing this huge, huge project and on that Lancet publication, Lancet and Lancet Global Health. I remember, Dr. Bhargava, when you presented this to the ITRC, I was part of that group. I think it was 2016, and many of us had doubts about the huge grant that you were asking and how you would be able to complete it. But very pleasantly, surprised that you were able to complete and take it to the conclusion and through this wonderful publication that has come out. This has caught the attention of the scientific community, not just the TB researchers worldwide, and it deserves the place, Dr. Madhavi, where it is now. So congratulations again. And your work and life both are actually inspirational. Uh, I had followed your work. I mean, we have been listening to Dr. Anurag for past few years. He has come to our meetings and the recent rations trial that you completed. But after today's presentation, listening to your background, now I'm able to understand what has formed the base, a solid base on which such a mansion could be built. I mean, your previous background, your work in this area, it's really inspirational. And I was thinking, you practice what we preach. As public health professionals, we teach and preach a lot, but you have been practicing. So the chat box is full of, I mean, exclamations, comments, and very few questions till now. But we would welcome questions from whoever wants to put forth. There are one or two. Just before I read through the questions, one or two of my doubts, Dr. Anurag and Dr. Madhavi. First thing I had in mind was the nutritional supplementation that was being given to the patients, how well they were able to take it. Because when you show patients with such severe cachexia, they must, were they able to consume all that 1200 kilocalories and 52 grams of protein? Were they able to consume and were they able to digest? There must have been issues of the food being shared with the households in the control arm as well. But that is despite that sort of a contamination, or the participants in the control arm also receiving some amount of nutritional supplementation, you have found this much of difference. That actually strengthens your study results. But how about the patients? Were they able to consume that much?
Yeah, I think, of course, with TB and especially with the extensive TB that often these severely underweight people, the appetite will be a challenge in the first few days. But as Madhavi said, that we were monitoring weight gains, and the 5% weight gain would translate to about maybe 2.5 kgs in the first 2 months. So whether they could start eating immediate, but I think within a week or 10 days, I think they start feeling better. Generally, that is what we're seeing. The first few days are difficult with therapy, and then the appetite returns. In our case, actually, our intervention was up to the enrollment was up to a maximum of 14 days after diagnosis. So some of the patients had already maybe completed those 2 weeks of initial problems. So we generally had a very positive experience of weight gain. What was seen as a problem for many people of food sharing, I think it's probably very difficult and unethical in this situation to talk of limiting the food, because the woman said that if my children are there, I cannot, and they want to eat this, I cannot deny them. So I think it's a pointer to that we need to do more. And when we are talking of food support, it always is seen as some kind of a charity or social intervention. Right now, in this kind of patient population, it is a part of therapy. Any nutritionist in the world will say, what do you do with a less than 16 BMI? They have to get adequate. In fact, we had to extend the food ration for many patients who still, despite the 6 months, needed a longer time to return to normal. So I think it should be seen as therapy for patients, but therapy that you're not giving lifelong as in a patient with diabetes or HIV, but maybe for 6 months up to 1 year. So I think something which will make them take the therapy better, make them return to work, should not be seen in these narrow terms, but as a part of patient-centered care that we are now, talking of globally. So if you're talking of patient-centered care, you cannot, not address their access to food as a part of therapy. And in the case of contacts, as you said, again, given the levels of undernutrition, and what the problem happens is we are always in public health looking at averages. So the average BMI in India is now better, but that doesn't mean that the poorest are really doing that much better, or so you have to look at the hotspots where undernutrition is still very highly prevalent. And we didn't share data here, but the prevalence of the national prevalence of TB is 293 or 316 per lakh. In Saharia tribals, which have higher prevalence of undernutrition, it is 3,000 per lakh. If you're talking of TB incidence, yes, 7 to 10 times more. You have, so this average is misleading, you know. So again, and now we have enough capacity in India to know where the problem is most acute and address it. So all the time, sometimes we are paralyzed by, you know, there has to be a national intervention. We can go nimble on that and look at the problem district by district, state by state, and just start doing it. And I would say if we do it well enough, success is guaranteed. And here, in fact, the biggest challenge for us, which was unanticipated, was COVID. So within 6 months of the enrollment, COVID struck and everything went haywire. So their livelihoods are affected, their food security is affected. So our intervention, probably what we are seeing is an underestimation of the effect. If the baseline intake was better, we might have had really even a better effect. So
just to add one, thank you for that explanation, Dr. Anurag. Just doubt about how sustainable you think this intervention would be, because you did as a program, as an intervention, but how good is the system there which can sustain these efforts?
So again, if I may, should I answer this question?
Yeah, you can answer.
So we are just again looking at two aspects. One is as part of therapy for patients who are having actually life-threatening levels of undernutrition. It's a clinical intervention which should be overseen by the program. And I don't think there is a problem if you're rolling out this Nikshay Mitra scheme and people are coming forward to support patients. I think there needs to be some modification in that so that no person is left out, just because somebody has not adopted this patient. So the clinical part should be overseen by the program. And what we are pointing out for the other thing, we have just shown that the efficacy of improving nutrition on TB rates. Now, that is not something that has to be taken up by the program and rolled out, but it is a public health intervention which should be part of the overall development agenda. And the most sustainable way of doing this would be to improve and strengthen our PDA system and include pulses in it, which was the critical component here. So we are giving a lot of cereals and maybe too much cereals in this thing. We have to diversify the food basket in the PDS, and that will be the solution to this. Apart from, of course, talking of wages, improving, food systems, etc. So it's a part of a multi-pronged thing to address undernutrition. But in terms of sustainability, we already have supplementary nutrition programs and the PDS. We just need to look at it from the point of view where this intervention is most needed. Probably not needed in Kerala or Tamil Nadu where obesity rates are high. But even within that thing, the tribals in Tamil Nadu or the tribals in Kerala might require this. So I think sustainability, and when we are talking of food, actually always people are calculating the sustainability thing. I'm not taking a comparison here, but if you have rolled out Gene Expert as a primary thing of screening all patients, and you're treating everybody with with sputum, with Gene Expert, how many things are you getting for 100 cartridges? Maybe you are getting 4 cases after spending about the equivalent of many thousands of rupees. So I think if we take comparison across, and what we want to say again is this is not a TB specific intervention. This is an intervention which is required for many other reasons in public health, for improving maternal mortality, from improving infant mortality, and will have an impact on TB. So if you take it in that, then I think it's just Madhavi will like
very true, Dr. Anurag. There are a number of questions which are rolling in now. We'll just take one by one. Sorry?
You can mute and reduce your volume.
So Dr. Ravi Shankar asks, this reminds me of a comment our surgery professor would say, have you heard a TB?
Sorry. That's not the question.
Oh, sorry. Okay, sorry. It's a comment.
The question was, I think Dr. Madhavi said she would answer. It was about if there were differential responses noticed in pediatric patients versus adults, and if there are planned pediatric analyses from the Rations trial.
Yes, Dr. Madhavi.
Yeah, so in pediatric household contacts, few important things is that one is the disclaimer. We have absolute weight gains in pediatric patients, So that ranges from 1.5 to 2 kg, and it is not very different in the two arms. The weight gain, whether in control arm or intervention arm, which is suggestive of some amount of food sharing. We could not do heights. So although we can say there is absolute weight gain, it is also part of that growing. So if we had done height and we had done Z scores in terms of height for 8 Z scores and BMI for 8 Z scores, that would have been wonderful. But because of COVID, our field workers were not able to do repeated heights on follow-up. Because it was a portable stadiometer, and it was and so although some of them did it, not all of them did, so we did not do that analysis. So that was one about the weight gain. The second thing about the incident TB. So as I said, mostly they were adults. We found pediatric TB was in 23, but more importantly, we found a lot of X-rays with healed mediastinal lesions. So we do not know how to interpret that, whether it was because of a delay in picking them up, or it was a nutrition that helped healing. And this was also colored by COVID. It was also affected by Jharkhand, where the primary health services do not have facilities for gastric aspirations, and diagnosis in pediatric is the most challenging part in that part of India. So Anurag, you want to add something in that? You can add.
About pediatric TB?
Pediatric TB.
Yeah, actually,
No, you have to also.
I would just like to say that actually we found the TB guidelines, the national guidelines for pediatric TB, unworkable in the community. It's not easy to do gastric aspirates. In fact, when we started work, nobody was doing gastric aspirates in the whole system. So I think we have to align or have a little more nuanced guidelines. When we impose one guideline saying that everybody will have a gastric aspirate with CB-NAT, it's not workable because the patient has to travel a long distance, get admitted the previous night, and in the morning then this. And gastric aspirate, again, positivity is not very high. So I think the reasonable thing is to have other criteria for diagnosis. In fact, the union has suggested that anybody with a contact with a TB patient is already very high risk. So if you have any suggestive symptoms or an abnormal X-ray, this should be considered, on the basis of clinical diagnosis rather than, because we find it very difficult to get this thing done in the week. And Jharkhand has only 2 medical colleges, overall. So only in the medical colleges were we able to organize this screening. But our advantages was that we were following these patients over 2 years. So in case they had weight loss or follow-up, again, we would, evaluate them. So nobody was missed, but it was challenging. And likewise, I think TPT is going to be a challenge even for household contacts because of the issues of excluding active TB in them, again.
Thank you.
Dr.
Can I
Anurag,
just piggyback one question? Can I piggyback one question if you don't mind?
Yes, sure.
Were there differences between the primary source, meaning pulmonary tuberculosis versus extrapulmonary tuberculosis? Were there differences in responses?
No, we had only enrolled patients with pulmonary tuberculosis who were microbiologically confirmed. So there were no.
I see. Okay.
There were no patients with extrapulmonary TB isolated in this cohort. The requirement was that the patient had to be had to have lung TB, which was confirmed. Yeah.
Dr. Anurag, there's also a question on any occupational hazards among the healthcare workers acquiring TB or MDR TB.
Yeah, so that was a point of concern because we were recruiting people from the local communities and young people. They all obviously had misgivings, but we had to explain how latent infection is as such quite prevalent in India, and they may be already infected. So we gave them sessions on cough hygiene and then protecting themselves. So they had access to this thing, protective N95 also during the COVID pandemic. We had to give them N95 also. But over a period of time, I think they got over that initial fear. We did have one person developing TB, but it was not a infectious thing, extrapulmonary TB during the this thing. The one field worker did develop TB. But they were again scared of COVID because COVID was again something new. But I think they showed remarkable, I would say, commitment once they felt that this was an important task. I think we somehow overcame those problems. There are many other anecdotes about what they were scared of. In fact, in the initial part of the trial, when they were carrying these large bags, one policeman said that you are Naxalites, going into the village. So some of them were caught by the police and we had to do some explaining here.
Thank you. Are there any questions which are still not answered? We still have few minutes, Dr. Vidya. There's a lot of response.
Some of the questions have been answered on the chat box. So if we have time, maybe we'll actually have verbal confirmation. So KK, would you like to come in now?
Yes, I'm sorry. I just was, I just wanted to, it's been overwhelming just listening to this talk, the kind of effort that has gone in. In fact, despite having read about it, I couldn't fathom what was done until I really heard this. Both Anurag and Madhavi, and this is a humongous trial on a scale that I don't think it's almost unprecedented. I don't think anything has been done, any clinical trial has been done on this scale in this country. And it's just been amazing to listen to it. So obviously, we all knew that it mattered, but getting the evidence and putting it out there was so critical. I do hope all this translates into some policy changes. I do see light at the end of the tunnel. I know I've met Anurag at his lowest moments of extreme despair when he was very frustrated with a lot of things that were not going as per his plans. But today, I think he would look back and say, no, maybe not. Maybe it wasn't so bad after all.
Yeah, so there are just questions about whether hepatitis was more, drug-induced hepatitis was more common in the underweight. Do you have any specific information on that?
So being underweight is definitely a risk factor for hepatotoxicity. Of course, we were limited by, the absence of monitoring. We were not monitoring LFTs. And we don't have a control arm here. So everybody got food. So we had only 8 patients who had documented symptoms suggest hepatitis and where the doctor, stopped the medicines for some time. So that seems quite a low figure given the kind of patients we had with high rates of undernutrition, also of alcohol use. But this needs to be really confirmed. But the biological plausibility says that you can actually, because they have problems, in the metabolism capacity, one would have expected a higher rates of drug toxicity in this group.
So if you want to elaborate a little bit on XDR and MDR incidents in such, they don't have access to healthcare and they are somewhat isolated. Does that actually protect them from XDR, MDR, or it's the same? And how did you manage that?
So I have been, fortunately in rural India, most people, and this, we assume that people who are dying of TB are dying of drug-resistant TB. No, 95% are dying of drug-susceptible TB. And in our cohort also, there are only 38 patients with MDR TB. So in fact, in the 108 who died, there was not a single patient with MDR TB who died. So actually, what counts is not only your drug resistance, but also, what is happening to the person as a whole. So if you're somebody who's very sick with drug susceptible TB, you're more likely to die than somebody with, localized MDR TB. So I can't comment on those other aspects here, but what we can say is that we had clusters of cases. And I'll have to look at the data again, whether we had a cluster of an MDR TB also. But some families actually had clusters of cases, 3 people also in the family developing tuberculosis. So that is what we saw. Apart from the generous appreciation of our work, which is very, very this thing, for us, it was very disturbing to document the problem in Chhattisgarh from 2004 and 9, and expecting improvement in Jharkhand, 10 years later, but again coming up with the same alarming figures of severe undernutrition. So I think we have to take a reality check here in our program, in where in India, this problem is there. We should be doing more and more, in a faster manner. Yeah.
So we have programs now rolled out by not necessarily every state government, but about extending diagnosis of diabetes, hypertension, and prevention of so many diseases. Do you think that the time has come where we should have a cutoff for a BMI and say that when they, the ASHA workers or anyone, when they go and check on pregnant women or someone, they should be actually checking up on people whose weight is disturbingly low, and maybe they should be treated just like patients, even if they don't have any disease, by nutritional supplement.
First, the patients.
First, actually, the patients, yeah. So people who are underweight and are losing weight, of course, they need to be screened for TB itself if they're losing weight. But we have, unfortunately, in India, about 140 million adults who have a BMI less than 18.5. So the numbers are huge. As Madhavi pointed out, I think we need a stronger primary care approach to all these problems. And what we found, with even a very low prevalence of diabetes, it was a risk factor for mortality, because patients were getting screened for diabetes, but they were not being treated effectively for diabetes. So the entire purpose of screening was lost because they did not have access to optimal care. So I think when you talk of nutrition, we, in general, if we are able to catch even people who are underweight and overweight and at risk of diabetes, and effectively have some strategy at the primary care level for dealing with these people, it will work. I think the key issue is strengthening our health system at the primary care level and make these things possible in terms of diagnosis and therapy. The patient right now with diabetes has to go to the CHC for treatment, and often the CHC is 60 kilometers away. So you cannot expect regular follow-up in that situation.
There's another question, Dr.
Sorry,
Vidya.
yeah, go ahead.
Here's another question. Have you seen immunological manifestation attributable to TB?
I'm not clear about that question.
So, Dr. Vidya, would you like to elaborate what exactly you were trying to ask?
Sir, I'm just curious to know whether there are certain immunological conditions that you've been attributed to TB in your cases, that directly not attributed to TB infection, but you think this is present and it's an immunological manifestation to TB. Was it ever seen?
That was really not a part of our research question or hypothesis.
I know. I know.
Not, yeah.
Not.
I'm not still a little clear, but in a sense, if I interpret your question broadly, whatever we get as symptoms are often there because of the immune systems, the cytokines, etc. So I'm not very clear. And if you're talking of unusual manifestation like rheumatism, that was not seen yet.
Yes.
Yes.
Like erythema nodosum attributable to TB.
So this was not a clinical study in that sense, that where everybody was, seen by a doctor and followed up by a doctor. So it was the program which was following these up, and we don't have data on that, unfortunately.
Sure, sir. Thank you. Thank you.
Dr. Vidya, can I ask one question?
Absolutely.
Dr. Anurag, with all this health and wellness centers coming up at the sub-center level, do you see any change in the delivery of the primary healthcare services in these rural tribal areas of Chhattisgarh?
I don't know enough about the situation after the health and wellness centers have been established. It's a good initiative, but I have not really followed up this because the staffing of these health centers, what they're able to do and what is their training, that will determine, and the delivery of the supplies, for example, drugs and the diagnostic equipment, I don't, it is still a challenge. Let me tell you this, to get a proper weight and height done in the public health system.
Yeah, we are not able to do that even now in the program. We are trying to, I mean, we're part of the group which is trying to advocate for inclusion of BMI. Height measurement is not easy. Yeah.
So,
I'll
Dr. Venkatesh
just
has an
add
interesting
that,
question. Sorry. Go ahead. Sorry.
That in Dakshin Kannada, which is supposed to be a better functioning, district in Karnataka, height and weight equipment is not available regularly, uniformly, and patients are classified according to, weight bands for nutrition status, or just by visual method, or by a height meter painted on the wall. So we have a long way to go. I mean, that is we are completely aware of that situation. That even in a better functioning place like Karnataka and Dakshin Kannada, if things are so bad, things are going to be very difficult as far as nutrition screening and assessment is concerned. But the fact that we are doing it for maternal, mother population of, pregnant mothers where height is being done, it is something which is probably doable.
So Dr.
Thank
Venkatesh
you.
has a question. Are there any other data regarding TB prevalence in other states where the PDS system is better?
Dr. Anurag, you're muted.
In general, if you see the, I would not say prevalence here, but in general, if you see the TB burden in India, it corresponds to nutrition status really in some ways, because Kerala is really at the bottom of, TB burden in India and has better public health indicators. And I think, again, I'm not the person to this thing, but it's both a combination of the system, health system, as well as their access to entitlements, which is probably this thing. But over a period of time, I think, again, my colleagues from Tamil Nadu will be able to say whether the midday meal scheme there and the other nutritional programs have had an impact on levels of undernutrition, growth, and disease patterns. I was told by a pediatrician that, for example, extensive miliary tuberculosis, disseminated TB, or TB meningitis is now very uncommon in Tamil Nadu in children.
Dr. Nandakumar, do you have any comments, sir? Dr. Nandakumar Menon? Meanwhile, Radhakrishna, over to you. We are almost, heading out of time. Radhakrishna was actually concerned that we may not have enough people who will be interested in this topic, but actually we had more than 70 people logged in at a given time. So over to you, Radhakrishna.
No, that isn't true, Vidya. I didn't mean that. See, actually, like many who voiced in this forum, that I also myself considered the privilege to listen to these two wonderful people. And a couple of things that intrigue me is that why these special people had moved from one place to another in India, and India only, although they can very well be in McMaster's and McGill, settled there abroad and not here with that Lancet publication. And then the scare, actually, by even as clinicians now, whenever we see an open tuberculosis, we'll do rounds from a distance. We don't go anywhere nearby. Where so many of the people worked very close with the patient, but I didn't find any doctors other than you two, or maybe one or two more. All others are non-doctors, and they are, I think they're quite well motivated. Then actually, I also am surprised that at the end of the study, well, the people went back to their malnutrition and things continued. And I don't know whether anybody has taken a leaf out of this book, and any governmental things happen to improve nutrition countrywide. And I'm also surprised that COVID didn't add on to mortality in this tuberculosis, because I thought COVID will wipe off those people who have poor lungs to start with. And then how was the food package? Because the whatever thing I see is a very bland, the dal powder and oil. How can that be consumed, especially when these people eat, food which is attractive and tasty? But they're all the things which I keep wondering. And the last thing that intrigued me is the last picture you showed is full of boys. There's not even a girl in that, who contributed to the Lancet paper.
You can just hold your comments. I will come back to both the Bhargavas. We have Dr. Nandakumar here.
There are too many comments I made, so I would like to address.
Just give me a moment, Dr. Nandakumar, because specifically Dr. Anurag asked comparison with Tamil Nadu, so that's why I wanted Dr. Nandakumar to come in.
Yeah, I think what Anurag and Madhavi have shown is things that we have been seeing and observing over a long period of time. The fact that our tribal patients are malnourished, and a BMI of 18 is and lower is quite common. Weights of our usual admission weights are around about 28 to 30 kilos. So whatever you said is absolutely correct. Nutrition is a key part of the treatment, and unfortunately, a lot of the logistics of supplying the food is quite difficult on a sustainable basis because our villages are so scattered. So the challenge is going to be, as you said, is to increase the amount of protein. We are giving, in our PDS right now, we are giving 25 kilos of rice free to each household. Unfortunately, the lentils have to be paid for. And although it's subsidized at 40 rupees a kilo, very few people access it. So as you suggested, I think at a certain cutoff, maybe we should have 18 or 18.5. This should be considered as a supplement which must be given. I don't think there's any doubt that that TB and many other illnesses, and even the chronic malnutrition causing decrease in the work output, they have tremendous impact in our country on the economic front. I think if we can just supply that so these people can go and do work, proper work, I think it's critical. As you said, if food here is not to be considered as something as a freebie. If we can do it for diabetes and hypertension, and as you said, spend a lot of money on these lab tests, we certainly can give it for people who are chronically malnourished. To answer the question regarding the use of ICDS, the tribal children find it quite difficult for many reasons to access the ICDS. So we have actually found it quite sad that this is a situation. So many of our villages, we actually have to intervene with physically carrying the food and providing it for the under fives. So the program, the government has made these centers available, but the way it is run by the non-tribals, sometimes the tribals feel excluded for so many, what we would consider minor reasons, but for them, those are important enough, self-esteem issues and so on. I mean, there are a lot of small things that come in, distance from their villages and so on. So we're working hard to see how we can supplement the food. And as Anurag and Madhavi has shown, undernutrition has a tremendous effect on the growth of these children, the capacity for intellectual development. All these things are affected by the time they're 5 years old. Thank you.
Dr. Anurag and Dr. Madhavi, can you just split all the things that intrigued Radhakrishna? Maybe you can start with the end. How come the bye-bye photo had only men in it? Only boys and no girls.
Okay. No, one requirement very purely on basis of logistics was their ability to ride a vehicle and have a license. So that unfortunately in the terrain of Jharkhand really slanted it towards men. So when we downsized again, there were some women who are going with, there were 2 people per block, but ICMR said in third year you can have only 1 field worker per block. So then the lady who was riding on the pillion would be left without transport if we had only 1 person. So it was a painful decision, but we had to take it to keep the trial going. Budgetary constraints, and again the terrain is quite challenging. Had it been just an urban facility-based trial, then this profile would have really been different. But this was a field trial. Regarding,
I did read your paper, and I know about how the ingredients were meant to be used in recipes. So if you could just elaborate on that. How did you choose what was being supplemented and what was expected to be done by the consumer for it?
So our deliberate attempt here, and it is almost like a very firm decision that we will not go into processed food. or any commercial product like a ready-to-use therapeutic food, because that will just sort of distort the message that we wanted to convey. And the rations is actually truly just food rations. So we wanted to show, see whether food rations in this form can make a difference, and they seem to have made a difference. Regarding choice of the package, we had, as we pointed out, a guidance document, and a committee of people, including nutrition people, TB people. They all gathered in a consultation and evolved this kind of a package for TB patients in India with certain assumptions. So this was just taken, on the basis of the guidance document, but locally adapted, because as Madhavi said, groundnuts was going to be a problem. In the first batch itself, we had problems. So we just stopped that and substituted again in consultation with colleagues with sattu. And sattu, as Madhavi said, can be taken as a drink. You can just mix it with water and consume it with some salt, or you can make it into a laddu, or you can make it into a paratha. It's a very versatile food, actually. And if you ever travel to Jharkhand, you can have good parathas with sattu. And there's so it's a versatile thing. And this was told to this thing, and most people knew about it also in that belt. So
how do you explain not having increased mortality?
One issue was consumption of milk in tribals, because that is not a part of their usual diet. So if you're giving milk powder and they're not usually consuming that, sometimes they had misgivings that this will cause indigestion. They all have their things. But we are coming out with an independent group did a qualitative study in these patients about what they perceived about this food basket. So if you in a few months, we hope to bring out that paper, which will have the whole, what was the perception of the patients and their families about the quantity, quality, and the components of the food basket. So we'll be able to really answer those questions. Yeah, you were asking? Sorry.
Yeah, one initial question I asked is that having trained from very elite institutions, you picked a topic which is not the commonly picked up ones, and you've been in many parts of India, moving all around, still staying in India and not gone and settled abroad.
Why now?
Yeah, for a pure sabbatical or a break, we would not mind going on for some time. Yeah, we have. So I cannot answer that question really. This thing, but as I said, I was not a AIIMS graduate to say, and I came from Maharashtra. I have stayed in Maharashtra, so there are connections that we feel with this country, and I am personally very deeply into reading about India, our history, our culture. I'm fond of music, including classical music. So in some ways, the roots are there. But on a very practical basis, if you just even say that I got a position at McMaster's or McGill after doing my MSc there, I would have made zero difference in Canada. Actually, I would have been just part of the system and training people. But to think that I can influence Canadian policy on anything is out of question. The paucity of information is here. The interventions are required in our country, and really, at all levels, we need to go to the ground and see the situation for ourselves. I think it's very dangerous to have policy making occur with people sitting in Delhi or people in tertiary care centers planning for the thing. So I think that approach has to change. So even if you're living in India, but you have not seen the field reality and are making policies, that is actually as as removed. So some people said that there are non-resident Indians and there are resident non-Indians. So you can be as disconnected.
Dr. Venkatesh, you had a lot of comments.
Wonderful,
in the chat
great
box.
reply,
Like
Dr. Anurag.
Dr. Venkatesh, would you like to
Yes, ma'am.
a summary of all your comments? Yeah.
Yes, ma'am. Excellent study. This is a remarkably well done, large scale intervention. I mean, which clinicians would lap it up. And the amount of hard work that goes into this kind of performing a study in a country like ours is tremendous, especially the practical difficulties that are involved in taking fundamental healthcare to very people living in the fringes is extremely difficult. And I would congratulate both Dr. Bhargavas for their excellent work and for contributing to the well-being of the country. So my question is, I joined late, so I missed a bulk of the portion of the presentation, but I went through the paper in a hurry just to see. But what struck me was two things. How common is alcoholism among the tribal population, especially in the interventional group, number one. And number two is the nutrition. When it comes to nutrition, was there any analysis of the baseline nutrition of these patients in whom the intervention was actually planned?
So alcohol use, now I'll distinguish between alcohol use and alcoholism because the two are not synonymous.
Yes.
We often, I have to interrupt my students all the time when they say this patient is alcoholic. That's not true. So alcohol use is socially sanctioned in tribal communities and it's common across gender. But what we are seeing more as a problem now is actually unrestrained alcohol use where the social norms are not, operating anymore. So alcohol use was very common and almost 50% of our patients had, reporting alcohol use. We could not really go into the depth. We asked questions indicating dependence, but yes, it was a significant factor in some patients on, stopping treatment or in recurrent disease. So some of these patients were, clearly alcohol dependent and they would, put alcohol in front of everything. We had a session on training these our staff on how to address alcohol use disorders. So somebody from AIMS was brought in and he addressed the whole team. And I think some of that intervention also helped. What was very, in fact, I will say it again, but as I said, we are representing the work of people. But what was very nice to see in this trial was that, the connections which are made between the field workers and patients. And there are anecdotes after anecdotes where we would exactly ask, oh, this is the 12-year-old child, of this person. How is she doing? And they would mention the name of the child. Or we would say that two children, how can they have the same weights? He says they are twins. So they had a very engaged, and that is actually the most, this is not the forum, but I saw two levels of India there. One is the administrative India sitting in Ranchi, where actually things are very difficult to move. Sorry to say, but you have a particular problem with the administration, the bureaucracy there. But at the field level, once you are rolling something out and people recognize the relevance or importance, then things happen there. So that was the most encouraging thing, despite what KK said had frustrations of sometimes with the funding agency, the food prices have gone up and we are not getting commensurate increase in funding, etc. But what was so remarkable was that people who are non-medicos, you can train them to recognize, saturation, blood pressure, they connect with people and make a difference. So I think that was really the key thing. And maybe we provided some of that motivation because of our own experience in tribal India. In retrospect, if somebody tells me now to do this trial, I would say no. All of these things happen in a fit of madness. And when you don't know what you're getting into, once you go there, it is and there are anecdotes and anecdotes, So once we were holding the interviews for these people, and suddenly there was a flash strike by nurses in the same place, and they drove us out. He said, "How the hell can you have interviews when we are on strike?" So we were unceremoniously dismissed out of that building, and we were standing below trees. How to interview these 240 people. So. So a lot of things there are, but it's organized chaos in a way. But I feel I have a great, faith in the decency of common people in India, and the fact that if you operate, at one level when they are convinced, I think we are capable. We are already doing great things on the ground, but.
Professor Ananthakrishnan, sir, we'd like to hear from you. I know you put your comments on the.
I really don't have much to add to what I've written in the chat box, Vidya. A remarkable work. And I like the policy implications of what Anurag and Madhavi said, that we can't really have all these things planned and implemented from the center. It has to be targeted to the areas which most require, and the interventions in each area may be very specific to that particular area and that particular disease. So I think that itself is a great contribution apart from the very large study that they have published.
I'd like to hear a take home. Yes, Dr. Venkatesh, what did you want to say?
Sir, I would like to ask one question. May not be the right occasion, but still I would like to ask it because I believe that medicine is a social science and it's important that we understand the perspective. Did this work in any way impact social policies or public health policies in the state concerned?
Yes, so we have, our obvious thing is to see changes occur in the national level and the state level. And believe me, we have tried our best we have prepared a policy brief which we have shared with the ministry and with the state government. But as I said, that this is a process, we are feeling a little that things can move faster, but we are hopeful. On the other hand, two other states like Chhattisgarh, there was actually, the problem also has been that, there have been elections in one state and then the governments changed and Bihar is again facing, so Chhattisgarh, Bihar, there was some real thing that, they would maybe take this up. But right now, it's all on hold. But so we have actually assembled a policy brief based on the trial, which we have shared with the government. We are sharing it with anybody who has an interest and a power to do something. But as you said, you very correctly said that medicine is a social science. And I think we, as a very group of people, who have influence, I think we should engage in these broader issues maybe more so that they get sensitized. Because otherwise, it's a few voices saying that this is important. But I think once everybody is on the same page and say that this is a issue that demands attention. One, I think, parallel I can say here is we always find it difficult to say that we are facing a problem of undernutrition. So we have to recognize that the problem exists and the problem exists to a very serious level in our communities. If you're going to downplay that thing and say that, no, this is not true, because this was the same situation in, for example, USA, when, Joseph Goldberger went to investigate what was told to him is an infectious disease epidemic. But he found that it was pellagra because of poor nutrition. So the US government was very difficult to accept that, this is the diet of cotton mill workers. So I think if we say that, yes, we have a problem of undernutrition and the first SDG is of nutrition and, related to nutrition poverty. If you're talking of, sustainable development goals, this is right up the list there.
Thank you so much, sir. Thank you.
Yeah. So, Dr. Anurag and Dr. Madhavi, if just take home.
I'll just add something on a positive note.
Sure.
Very small thing that we started with complete resistance, and here we are presenting to this forum. We have made multiple presentations, so we've been able to convert a lot of people, and I would say I'm very, very hopeful about it. So it's something which I don't feel disheartened at all. The fact that we have so many converted people, it's a very nice thing. That's all I wanted to add.
Ma'am, you never quarreled as husband and wife while doing this study saying, get lost, I'll not cooperate with you. That never happened.
I don't think that happened, but yes, we have a lot of academic kind of fights about design, about analysis, about going about, logistics and planning, etc. But I would say they are cute fights. So.
I just wanted to.
We listen to Anurag is saying something about this.
So on a personal note, actually, I must say, it's not about me going to the US like many other AIMS people. I went to Gujarat. Madhavi had a much more brilliant track record as an undergraduate. She's 5 gold medals in an undergraduation, top student of her batch, etc. And within 3 years of marriage, going to, agreeing to even go to that, place where there's nothing except old go downs. I think whatever I've been able to do is, really because she had the same wavelength and did not ask for, what some people would usually ask for in life. And I can conceive things, but she's a very good person to execute also. So the whole chaos of, organizing the logistics and maintaining the accounts. And in India, actually, the problem is again that our systems are not well built. So all this goes to her. So I'm really, in one way, not the dreamer and doer, but yeah. But nobody who has been with the track record that she had would have agreed at that time to even start the journey. So I think we have both been fortunate, and our marriage has survived the trial as well as our journeys across India. So I was very pleased that we celebrated the golden silver jubilee of our marriage somewhere in the trial period.
Yeah.
Wonderful, wonderful.
Yeah, hope you'll be still publishing trials on your golden jubilee as well. So the point I was trying to get in is I just want, I know you've been talking so many things and most people have understood, but still each of you, I would like you to give us 3 take-home points from this whole journey of yours, and also, related to TB as well. And what would you like to emphasize? Because we have surgeons, we have nephrologists, we have cardiologists, we have ophthalmologists, all kinds of people in this audience. Probably not enough preventive health specialists today, but just what do you want to
take home point is Dr. KK's final comment on the screen. Yeah. Now, actually, somebody was also commenting whether, how should the younger generation get inspired to, do this sort of a research? I mean, you can say in that direction. Anurag, your microphone is...
You're muted.
Yes.
So both of us actually did not start with any plans to do research. I was very happy treating patients and, moving to rural India and establishing. I ran the pharmacy for JSS for 10 years. So I was very happy doing that. But I think what we saw, and we realized that this was a gap and nobody else was looking at it. That is where we stepped in basically. And I think there is something very, I have shown you pictures, but it is deeply disturbing to see these things out in the field. They militate against all your ideas of human dignity and, what a life should be. So I think that concern and maybe passion can drive certain things. I see a similar problem. So undernutrition, if I say, or nutrition, if I say, is absolutely central to any idea of health. And Hippocrates, nobody can do better than Hippocrates, that if everybody could get, the food that they need, not less, not more, and everybody would exercise the normal, not less or more, you would have found the key to health. Now, nutrition itself is a cross-cutting issue. And while every time you present this, everybody will say that there's a problem of overnutrition in India. That's not overnutrition. Actually, again, it's imbalanced nutrition and this thing. So our literacy regarding nutritional issues, even as doctors, is very low. How many people are writing a nutritional diagnosis of BMI on their, prescription slips? So our training in undergraduation is poor at the moment. We need to have training modules in nutrition, how to address undernutrition, how to address overweight, obesity. Because that is, so what we found, and this is for another time, that undernutrition is a no man's land. So you have communicable diseases, you have non-communicable diseases. Undernutrition is the no man's land, which is affecting both of them. So if you come to, Mangalore and see, you'll see typically a woman who's 142 centimeters height, but who has abdominal obesity and diabetes. So you have actually both the things in the same person, and undernutrition in the intrauterine phase and, during early life with poor muscle mass is actually setting the stage for the diabetes epidemic in our country. It is one of the contributing factors. So I think when we are dealing with the whole range of problems in India, nutrition is very central. We need to have better literacy amongst people. Everybody is into food fads now. People are taking all kinds of diets and mystifying the issue, whereas it should be very simple. So we have to start with better training in our students, in our residents, and really communicate the facts to the larger population of people here. I think we need playgrounds in our schools. We need better nutrition. I think good breakfast. We were fascinated in Finland when we saw that there was a lunch which was assured for all working people, a good lunch, which is balanced. So these are the kind of investments which will actually pay so much in the long run. But what we are grappling is with a twin burden, and often in the same people, and with very, very harmful effects. The high cereal diet is also actually, KK will understand this, is also a risk factor for cardiovascular disease. So anyway, that's another issue, but I think it's very central to any, and I will end with this, that on the hopeful note that Madhavi is saying, we have to recognize that India is one of the few countries in the world where economic development has not led to increase in height in all population groups. Our heights have been by and large static, and in some populations, it's actually in the decline. So if we take an overall view of nutrition, we have much work to do in all ways. But it should not be simplified that if you're giving 1 kg dal for a family in COVID time, that is addressing their protein needs. It is not. I think we have spoken a lot.
No. This is actually an example of the best example of research coming out of the need of the policy gaps and exactly how it would, affect the policy making in the country. It's an excellent, with lots of words to explain, how important this is. So, Dr. Vidya, should we close?
Yeah. Dr. Madhavi, your closing comments, and then KK, your final word.
You're muted, Dr. Madhavi.
I was just typing my thank you message, so I don't have much to add. I'm very grateful to be part of this august audience of some very senior people who have seen much more than me. And thank you so much.
KK, your...
Just have typed my last comment, and I think I'll just read it out and saying that this recording should be shared by key policymakers. We can find a way to make an edited version of it. I think the question and answer session brought out so many fantastic insights out of Anurag. So it was very, really revealing, and lots of that has important messages for the country. So we got to find a way to make this a very slick YouTube video and actually share it more widely. I'll do my best in promoting it.
Thanks, KK. We are actually hoping to do that to most of the videos, because we realize that the length of the program is not conducive to the short attention span of youngsters. So we are working on that. So maybe we'll take this as the first project, Radhakrishna, instead of going to our archives. Thank you.
What Puneet was saying just now, I think undergraduates desperately need to, every MBBS graduate listen. This is so inspiring. And it's not about, the government telling you to go to work in the villages and all that. Here is an example. You need to actually see this. You don't need to read textbooks. You need to listen to this talk. It's much more illustrative than any PSM textbook or a didactic session that you can hear from, and with due apologies to community medicine teachers. This is really life, and teaching our medical students about how to translate what your deepest convictions, how do you translate them, how do you transfer them into actions. So something that everybody should see.
Yes, Dr. Anurag.
No, I would like to add on this positive note that some of Madhavi's students actually have gone and worked in rural Odisha and Kalahandi on their own volition. And so these are hopeful signs, when people are coming to know, and generally we find a lot of students who can actually be guided. Thank you again for this wonderful session. It was very heartwarming for us, as I said. Thank you so much. This has been very...
Puneet, you're closing it?
Yeah.
The only point I want to make, like Burkitt's hypothesis on colorectal cancer about fiber, unfortunately, is known more for lymphoma, but not only showed that colorectal cancer actually, reduced, but a whole lot of other cancers from fiber was reduced. The potential for nutrition to affect not just TB, but so many others in a otherwise, undernourished country is immense. So I think this is absolutely stunning, firsthand, first degree prevention, primary prevention tool, absolutely stunning. I'm going to make sure that every undergraduate sees this lecture, even if it's, I think the unedited raw version is much more important, even if they want to see it at double speed.
Yeah, so you guys all have to help us to reach out to the, because
Absolutely. This is the best session.
Krishna have got anything to do with the medical college, so you have to help us to reach to these kids. So we'll get back to. So thank you so much, everybody, for KK for sharing the article with Ravi Shankar, who then thought of sharing with me, and a special thanks to Dr. Anurag and Madhavi for immediately accepting. I know you have a lot of, for want of a better word, more important and better things to do, but as immediately you accepted and we could come on a date, fix a date. And thank you, Sonali. I really reached out to you late, but you were absolutely sporting. And KK, of course, was already on board from the beginning. So thank you to all the people who have stayed here for more than 2 hours. And it goes to show that, people are interested in things that are important and that actually touch a lot of people's lives. So thank you, everybody. We'll see you again next week with another episode of Marvelous Medicine. Till then, take care and stay safe.